Harold was 71 years old the morning his wife called the ambulance. He had not had chest pain. He had not clutched his arm and fallen. He woke up confused, slurring his words, unable to find the right names for things. His coffee mug, his wife's face. By the time the paramedics arrived, half his world had gone gray. He had a massive ischemic stroke. The clot had formed during the night, silently while he slept. When I reviewed Harold's full medical history, every prescription, every over-the-counter medication, I found something that stopped me cold. Not one dangerous factor. Five ordinary medications, prescribed and recommended by well-meaning doctors, quietly building the conditions for exactly what happened to Harold that Tuesday morning. None of those medications were unusual. You have almost certainly heard of all of them. There is a reasonable chance that you or someone you love is taking at least one of them right now. The doctors who treated Harold were not negligent. They were working within a system that fills a 7-minute appointment with a checklist and a signature, and is structurally incapable of asking the one question that might have saved him. What is the combination of these medications actually doing to this specific patient's cardiovascular system over time? Nobody asked that question. Nobody had time to ask it, and Harold paid the price. Today, I am going to ask it for you. I am Dr. Ryan Mitchell, a cardiologist and cardiovascular research physician with 25 years of clinical practice. I have reviewed thousands of cardiac event files, contributed to pharmaceutical safety research, and served on hospital ethics committees reviewing adverse drug event reports. I am not anti-medicine. I am not telling you to throw away your prescriptions. What I am telling you is that the pharmaceutical industry is a business, and like any business, it responds to financial incentives that do not always align with your best interests as a patient over 65. The research that proves every risk I am about to describe exists. Some of it was published by the same companies that manufacture these drugs. The problem is not a shortage of information. The problem is a system with no financial incentive to make sure that information reaches you. You are about to receive the conversation that Harold never got. Before I name the 5 pills, you need to understand one fundamental truth about the aging cardiovascular system, because it explains why these medications are dangerous in the elderly, when they are comparatively manageable in someone 30 years younger. By your mid-60s, your arteries have accumulated decades of micro damage. Vessel walls are less elastic. The endothelium, the single-cell lining of every artery, which keeps blood flowing freely and clotting appropriately, is less efficient. Your kidneys are operating at 60 to 70% of their capacity at 40. Your liver metabolizes drugs more slowly. A drug dose that is safe in a 50-year-old may be significantly more potent and more persistent in a 70-year-old taking the exact same dose. Almost no drug on the market was originally tested in the elderly population at the doses routinely prescribed to the elderly population. There is also the polypharmacy problem. The average American over 65 takes 4 to 5 prescription medications simultaneously. Each was tested individually. Each was approved individually. What happens when you combine 3, 4, or 5 of them in an aging body? Nobody fully knows. The interactions are not always tested. The combination effects are not always disclosed. This is the environment in which the 5 pills I am about to discuss operate. Not in isolation, in combination, in aging bodies, over years. Let us start with the most widely used and the most catastrophically underestimated. Ibuprofen, naproxen, diclofenac, non-steroidal anti-inflammatory drugs. You can buy ibuprofen at any petrol station without a prescription. Most people over 60 take them regularly for arthritis, joint pain, or back pain. They are perceived as harmless. They are in virtually every medicine cabinet. They are not harmless, and the evidence has been clear on this for over a decade. The mechanism NSAIDs block enzymes called COX-1 and COX-2. Blocking COX-2 reduces inflammation and pain, the part you feel, the part the advertising shows you. What the advertising does not show you, COX-2 also produces prostacyclin, a compound inside your blood vessel walls whose job is to prevent platelets from clustering and keep arteries dilated and flexible. When you block COX-2, you do not just reduce inflammation in your knee, you reduce prostacyclin throughout your entire vascular system simultaneously. At the same time, NSAIDs do not block thromboxane A2, a platelet clumping compound produced through a different pathway. You have removed the brake on clot formation while leaving the accelerator running. The result is a prothrombotic shift. Your blood becomes more prone to forming clots. In arteries already narrowed and stiffened, that shift accumulates with every dose. NSAIDs also raise blood pressure by causing sodium and water retention and blunting the effectiveness of most blood pressure medications. A 2017 meta-analysis in the European Heart Journal found regular NSAID use raises systolic blood pressure by 3 to 5 points. In a healthy 30-year-old, barely meaningful. In a 70-year-old with arterial stiffness, it translates into elevated stroke risk, sustained across every hour the drug is active. In 2004, Merck's COX-2 selective NSAID Vioxx was withdrawn from the market after a clinical trial showed a doubling of cardiovascular event risk. The drug had been taken by an estimated 80 million people. Merck later paid $4.85 billion in settlement. Documents released during litigation showed that internal researchers had data suggesting elevated risk years before the drug was withdrawn. In 2015, the FDA strengthened its existing black box warning on all NSAIDs, prescription and over-the-counter, to state explicitly that NSAIDs increase the risk of heart attack and stroke, that this risk begins even in the first weeks of use, and that it is higher in patients with existing heart disease. This warning is printed on every box of ibuprofen in America, in type small enough that most people never read it. A 2017 systematic review in the BMJ, analyzing over 446,000 patients across 474 trials, found that all NSAIDs studied increased cardiovascular risk. Diclofenac and high-dose ibuprofen showed the most concerning signals. The authors concluded that diclofenac should not be available over the counter. It still is in many countries. For chronic joint and arthritis pain in patients over 65, topical NSAIDs, diclofenac gel applied directly to the affected joint, achieve local anti-inflammatory effect with approximately 90% less systemic absorption. The cardiovascular impact is dramatically lower. This is supported by guidelines from the American College of Rheumatology, specifically for older adults. Acetaminophen at appropriate doses remains a safer option for many types of chronic pain. Omega-3 fatty acids at 2 to 3 grams of EPA and DHA daily have genuine evidence for reducing inflammatory markers. For the daily background pain management that drives chronic ibuprofen use in the elderly, the risk-benefit calculation has shifted significantly. Question for the comments: are you or someone you care for taking ibuprofen or naproxen regularly, daily or nearly daily? If yes, and nobody has discussed the cardiovascular risk, that conversation is overdue. Pill 2. High-dose statins for primary prevention over 75. Let me be precise about what I am saying here, because this pill is nuanced and the nuance matters enormously. Statins save lives in patients with established cardiovascular disease. The evidence for secondary prevention, patients who have already had a heart attack, stroke, or diagnosed coronary artery disease, is robust, and I do not dispute it. I have prescribed statins thousands of times, and I stand behind those prescriptions in the right clinical context. What the evidence does not support, and what represents one of the most commercially successful expansions of a drug category in history, is the aggressive prescription of high-dose statins to patients over 75 for primary prevention. patients who have not had a cardiac event, patients being treated based on a cholesterol number rather than a clinical history. The CoQ10 problem. Statins work by blocking HMG-CoA reductase, the enzyme in cholesterol synthesis, effective at lowering LDL. What is not prominently disclosed, this same pathway also produces coenzyme Q10. CoQ10 is not a supplement industry invention. It is a mitochondrial cofactor essential for cellular energy production in every tissue in your body. It is particularly concentrated in your heart muscle, which has the highest energy demands of any organ. CoQ10 is how your heart cells make ATP, the energy currency that powers every contraction of every heartbeat. Multiple studies document that statins reduce circulating CoQ10 levels by 30 to 50%. High-intensity statins, atorvastatin 40 to 80 milligrams, rosuvastatin 20 to 40 milligrams. The doses now routinely prescribed cause the most significant depletion. In a patient over 70 whose heart muscle already shows age-related stiffness, a 30 to 50% reduction in cardiac mitochondrial fuel is not a laboratory finding. It is the mechanism behind the fatigue, the muscle weakness, the mental fog, and in a significant subset, measurable deterioration in cardiac function. Symptoms routinely attributed to aging and never connected to the statin on the prescription list. In 2016, a landmark paper in JAMA Internal Medicine analyzed data from over 46,000 patients over 75 and found no statistically significant reduction in all-cause mortality from statin therapy for primary prevention. If you are over 75, have never had a heart attack or stroke, and are taking a statin purely because your LDL is elevated, the evidence that it is extending your life is at best weak. Statins are the best-selling drug class in pharmaceutical history. Atorvastatin alone generated over $12 billion annually at its peak. The cholesterol guidelines that determine when a doctor prescribes a statin are written by committees that include physicians with documented financial relationships with pharmaceutical manufacturers. This is disclosed. What is rarely discussed is the structural effect those relationships have on where prescribing thresholds are set. If you are over 75 and taking a statin for primary prevention, no history of heart attack, stroke, or diagnosed coronary disease, ask your doctor, what is my absolute risk reduction from this medication? Not relative risk, the absolute number. How many fewer cardiac events per 100 patients over 5 years? Then weigh that against the side effect burden and the CoQ10 depletion. If you are taking a statin at any age, ask about CoQ10. The evidence-supported dose is 100 to 200 milligrams of ubiquinol daily. There is no patent on CoQ10. There is no pharmaceutical profit in recommending it. That is entirely why most doctors do not mention it. Pill 3. Long-term proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole, esomeprazole. The most commonly prescribed class of medication in the world. Roughly 15% of the entire adult U.S. population takes one. Many have been taking one for years, some for decades. They were originally approved for short-term treatment of reflux and ulcers, 8 to 12 weeks at most. They are now routinely prescribed indefinitely, with no planned end date and often no reassessment. For the cardiovascular system of a patient over 65, the long-term consequences are genuinely alarming. Magnesium depletion and the electric heart, PPIs, dramatically reduce stomach acid. Stomach acid is a physiological gatekeeper essential for absorbing multiple nutrients, including magnesium. Magnesium regulates the ion channels governing heart rhythm. It is the mineral that keeps the heartbeat steady. Magnesium deficiency is directly associated with cardiac arrhythmias, including atrial fibrillation, one of the leading risk factors for stroke in the elderly. In 2011, the FDA issued a safety communication warning that long-term PPI use can cause dangerous reductions in magnesium levels. A 2016 study in Circulation, Cardiovascular Quality and Outcomes, using data from over 162,000 patients, found PPI users had a 16 to 21% higher risk of cardiovascular events compared to patients taking H2 blockers for the same conditions. The mechanism: PPIs damage the endothelium by reducing the production of dimethylarginine, directly impairing the vessel's ability to dilate and increasing vascular resistance. B12, homocysteine, and artery damage. Long-term PPI use also severely impairs vitamin B12 absorption. Your body requires stomach acid to release B12 from food. Suppress the acid, suppress the B12. A 2013 JAMA study found patients who had taken PPIs for more than 2 years had significantly lower B12 levels, in a population already losing B12 absorption naturally due to age. B12 deficiency leads to elevated homocysteine, an amino acid that, when it accumulates, directly damages arterial walls. Elevated homocysteine is an independent cardiovascular risk factor comparable in magnitude to high cholesterol, according to multiple meta-analyses. And it is almost never measured in standard blood panels. Your doctor checks your cholesterol. Your doctor almost certainly does not check your homocysteine. When you take a PPI for months, your stomach compensates by upregulating acid-producing cells. Stop the PPI abruptly, and acid production surges back, often worse than before you started. The patient concludes they cannot stop. They resume it. The cycle continues indefinitely. This rebound effect is real, documented, and known during the drug's development. The solution, a gradual taper over weeks, is effective and rarely communicated because there is no commercial incentive to facilitate discontinuation of a drug generating billions annually. If you have been on a PPI for more than 8 weeks without reassessment, that is a conversation worth having. Ask for your B12 and magnesium levels to be checked. Ask about a supervised gradual taper if appropriate. Ask whether dietary changes, positional changes, or H2 blockers, with a significantly more benign cardiovascular profile, could manage your symptoms instead. Pill 4, calcium supplements without K2 and D3. This is the pill I find hardest to discuss, not because the science is complicated, because it was prescribed to millions of women, your mothers, your grandmothers, with complete confidence by doctors doing exactly what their training told them. And the data now suggests that confidence was, in a significant proportion of those patients, misplaced. Calcium supplements, 1,200 milligrams a day for bone health, standard of care for postmenopausal women for decades. In 2010, a meta-analysis in the British Medical Journal, 15 randomized controlled trials, nearly 12,000 participants, found that calcium supplementation without co-administration of vitamin K2 and D3 was associated with a 30% increase in cardiovascular event risk. The study's senior author stated the risk was sufficient to reconsider routine calcium supplementation in older women. The mechanism: when you eat calcium in food, it enters your bloodstream gradually in amounts your body can direct efficiently to bone. When you take a high-dose calcium supplement, a large bolus enters the bloodstream rapidly. Without adequate vitamin K2, your body cannot direct it all to bone. Some of it ends up in arterial walls. Vitamin K2 activates a protein called matrix Glay protein, whose specific biological function is to prevent calcium from depositing in arterial tissue and direct it toward bone. Without K2, that protein sits inactive. Calcium drifts. Arteries calcify. A supplement prescribed to protect your bones silently hardens your arteries at the same time. The research on arterial calcification is unambiguous. Coronary artery calcium score is one of the strongest independent predictors of heart attack risk. And supplemental calcium taken without K2 measurably accelerates the process in a significant subset of patients. Why guidelines move so slowly? The 2010 BMJ meta-analysis was a major finding in one of the world's most respected publications. And yet calcium supplements continued to be routinely recommended for years afterward. Part of the reason is institutional inertia. Part of it is commercial. The calcium supplement market in the United States alone is worth over $2 billion annually. There was no financial incentive for manufacturers to publicize findings suggesting their products might be harming their customers' hearts. Do not stop abruptly, particularly if you have documented bone density loss. Instead, have a conversation about 3 things. First, are you taking vitamin K2 alongside your calcium? The evidence-supported dose is 100 micrograms of MK7 form daily. Most standard calcium supplements do not contain it. Second, are you taking adequate vitamin D3? Essential for calcium absorption into bone. Without it, supplemental calcium is even more likely to distribute into soft tissue. Third, can dietary calcium meet your needs? Dairy, cooked leafy greens, sardines with bones. These deliver calcium in the matrix nature designed for its absorption. Have you been taking a calcium supplement for more than a year without also taking K2? Leave a comment. I expect most people watching will answer yes. And this is exactly the information that was absent when that supplement was first recommended. The last pill is one almost nobody connects to cardiovascular risk. And that disconnection is exactly what makes it so dangerous. Benzodiazepines, diazepam, lorazepam, alprazolam, clonazepam. Z-drugs, zolpidem, zopiclone, zaleplon. Prescribed for anxiety, sleep disorders, and the relentless insomnia that affects a significant proportion of adults over 65. Over 5 million American adults over 65 are estimated to be on long-term benzodiazepine therapy. Most were initially prescribed for a short-term indication. Many have been taking them for years. What these drugs do to your heart? Benzodiazepines depress the central nervous system. This includes the autonomic nervous system, which governs heart rate, blood pressure, vascular tone, and the balance between sympathetic and parasympathetic cardiac control. Chronic use is associated with orthostatic hypotension, a sudden drop in blood pressure when standing. In the elderly, each episode is a brief ischemic event for the brain and heart, a moment of inadequate perfusion in tissue already working with reduced margin. A 2019 study in CHEST found that benzodiazepine use in heart failure patients was associated with significantly increased mortality. A 2022 analysis in the Journal of the American Geriatric Society found benzodiazepine use in older adults was independently associated with elevated cardiovascular event risk, even after controlling for the underlying conditions that prompted the prescription. Sleep architecture destruction. Here is the mechanism that most directly links these medications to cardiovascular harm, and the one the prescribing literature almost never discusses with patients. Benzodiazepines and Z-drugs do not produce natural sleep. They produce sedation, a pharmacologically suppressed state that resembles sleep but lacks its restorative architecture. Specifically, these medications suppress slow-wave sleep, the deep stage during which blood pressure drops by its natural 10 to 20%. Heart rate slows, arteries relax, and the cardiovascular system performs its most important overnight repair work. A patient on nightly benzodiazepines may believe they are sleeping well. They are unconscious. They are not waking up. But their blood pressure is not dipping. Their arteries are not recovering. Their heart is not getting the maintenance window that nature built into every 24-hour cycle. Night after night, year after year, the cardiovascular repair cycle simply does not run. This is the same nocturnal non-dipping pattern associated with the highest rates of heart attack and stroke in the elderly. And a significant proportion of long-term benzodiazepine users are living in it chronically, induced by the very drug prescribed to help them rest. If you have been on a benzodiazepine or Z-drug for more than 4 weeks, ask your doctor for a supervised tapering plan. The Ashton Protocol, a structured, gradual reduction method developed by pharmacologist Professor Heather Ashton, has the most robust evidence base for safe discontinuation and is freely available online. Never stop abruptly. always taper under medical supervision. For sleep specifically, cognitive behavioral therapy for insomnia, CBTI, has been shown in multiple trials to be more effective than benzodiazepines for long-term insomnia management, with no cardiovascular risk, no dependency, and no withdrawal. It is the recommended first-line treatment in every major sleep medicine guideline. It is recommended far less often than a prescription because it requires referral and effort, neither of which fit a 7-minute appointment. I want to step back and say something directly that every patient over 65 deserves to hear. The doctors who prescribed these medications were not negligent. They were working within a system. The average primary care physician in the United States sees between 20 and 30 patients per day. In that environment, there is not time to review the complete pharmacological implications of a 5-drug combination in an aging body. There is time to renew the prescription that worked last year. Into this environment, the pharmaceutical industry deploys an apparatus of extraordinary sophistication. In 2019, pharmaceutical companies spent an estimated $29 billion on marketing in the United States. The majority directed not at consumers, but at physicians. A 2016 study in JAMA Internal Medicine found that physicians who received a single industry-sponsored meal, average value less than $20, were significantly more likely to prescribe that manufacturer's brand-name drug over generic alternatives. None of this requires individual doctors to be corrupt. It requires only that the system creates incentives that consistently push prescribing toward more drugs, higher doses, longer durations, rather than fewer, lower, shorter, and more targeted. The consequence is carried entirely by the patient. The patient who takes the NSAID daily because nobody discussed topical alternatives. The patient taking calcium without K2 because nobody mentioned it. The patient on a benzodiazepine for 6 years because the withdrawal conversation never happened. Harold in the ambulance at 6 in the morning because nobody looked at the full list and asked the full question. Your action plan to do this week. Step 1. Make the complete list. Every prescription, every over-the-counter medication, every supplement, dose and frequency. Most older adults forget at least one. Do not guess. Check the bottles. Write them all down. Step 2. Apply the 5 questions. For each medication on the list, ask, is this on the Beers criteria for elderly patients? Does it deplete any nutrient essential to cardiovascular function? What is the documented cardiovascular risk in adults over 65? Is there a safer alternative with equivalent effectiveness? And when was this prescription last formally reassessed? Step 3. Request the conversation, not the renewal. The conversation. Book an appointment specifically to review your full medication list. Tell the receptionist that is the purpose. Bring the list. Bring the questions. If your doctor does not have time in a standard appointment, ask for a longer one or a medication review with a clinical pharmacist. Step 4. Do not stop anything without medical supervision. Several of the medications discussed carry serious rebound or withdrawal risks if stopped abruptly. The goal of this video is not self-prescribing. The goal is a better conversation. The information you now have gives you the standing to insist on that conversation until it actually happens. Nutrient support while you navigate these conversations. CoQ10, 100 to 200 milligrams daily if you are on a statin. Magnesium glycinate, 300 to 400 milligrams daily if you are on a long-term PPI. Vitamin K2 as MK7, 100 micrograms daily if you are taking calcium supplements. Vitamin B12 as methylcobalamin, 1,000 micrograms sublingually if you are on a long-term PPI. None of these require a prescription. None have significant side effects at these doses. All have published evidence of cardiovascular benefit in populations where deficiency is prevalent. Harold spent 11 weeks in rehabilitation after his stroke. He recovered partial speech and most of his mobility. He did not recover his ability to drive. He did not recover the easy fluency with language that had made him, his wife told me, someone who could talk to anyone, anywhere, about anything. He became quieter, more careful with words. She said it was like watching someone navigate a room they used to cross without thinking. 6 months after his discharge, we reviewed his medications together, all of them in detail, with his wife present for 45 minutes. 3 of the 5 drugs in this video were present in his pre-stroke regimen. 2 had been on his prescription list for over 4 years without a cardiovascular risk discussion. 1, the NSAID he took every morning for his knee, he had been buying over the counter. It did not even appear in his medical record. When Harold's wife understood what we had found, she was not angry. She was something harder to watch. She was quietly devastated that the conversation we were having in that room had not happened 4 years earlier. I am not making this video to alarm you. I am making it because I do not want to have that 45-minute conversation in the aftermath of something that cannot be undone. I want to have it here, with you, while all the options are still open. The 5 pills I have described are not rare drugs prescribed to unusual patients. They are in medicine cabinets on every street. The cardiovascular risks are not fringe findings. They are in the peer-reviewed literature, in FDA black box warnings, in geriatric prescribing guidelines. They simply did not make it to you until today. The 5 pills: NSAIDs, ibuprofen, naproxen, diclofenac, shift blood chemistry toward clot formation, raise blood pressure, and impair the prostacyclin protecting your vessel walls. FDA black box warning since 2015. Safer topical alternatives exist and are rarely offered. High-dose statins for primary prevention over 75. Depleting CoQ10, the mitochondrial fuel your heart runs on, by 30 to 50%. Weak evidence for mortality benefit in this population. The CoQ10 conversation almost never happens. Long-term PPIs, depleting magnesium, which governs cardiac rhythm. Depleting B12, which drives up artery-damaging homocysteine, directly impairing endothelial function. Trapping patients in a rebound cycle with no commercial incentive for resolution. Calcium supplements without K2 and D3, 30% increased cardiovascular event risk in a landmark 2010 BMJ meta-analysis. The K2 that directs calcium away from arteries is absent from virtually every standard calcium supplement. Benzodiazepines and Z drugs, destroying the slow-wave sleep architecture during which your heart repairs itself, causing nocturnal non-dipping, and keeping tens of millions of elderly patients in pharmacological sedation that feels like sleep, but is not. Which of these 5 pills are you or someone you love currently taking? Leave the number in the comments. It will tell me what video to make next, and it may matter to someone else reading who feels less alone knowing they are not the only one. If this video gave you information your doctor's appointments have not, please share it. Send it to someone over 65 on multiple medications. Send it to their adult children. Send it to anyone told their fatigue, brain fog, or irregular heartbeat is simply what happens when you get older. Because sometimes it is. And sometimes it is the pill on the nightstand. Take care of your heart. It has been fighting for you every second of every day of your entire life. Give it the information it needs to keep going.